So these are the three development, and two has already been in the regular practice. Thank you.
Thank you so much, Dr. Amit Joshi. Now, to elaborate on optimizing MRCC risk scoring towards better outcomes, I invite Dr. Shilpa Gupta, who's the Director, Genitourinary Oncology, Clinical Professor of Medicine at Cleveland Clinic, Taussig Cancer Institute, USA. Over to you, ma'am. You've got 10 minutes for your talk, and then we have 5 minutes for discussion.
Thank you, everyone. Really glad to be here. So we'll talk about the MRCC risk scoring towards better outcomes. As you all know, the International Metastatic RCC Consortium, or IMDC, is very useful and has really evolved over the last 2 decades as the treatment options have evolved. And a patient's individual risk for progression and death can be estimated according to this prognostic tool. And classification into favorable, intermediate, and high-risk IMDC correlates with survival and is the basis of treatment selection as well as clinical trial design. These were the founders who put together these retrospective databases from different institutions back in 2009 and started the IMDC at that time when we only used to have Sutent and Pazopanib, drugs like that. And now it has really evolved. You can go onto this calculator online and put the patient's details like the performance status, time from diagnosis to treatment, hemoglobin, neutrophils, platelets, and calcium levels, and then it tells you whether it's good risk, intermediate, or high risk. And back in 2009, as you can see here, the patients who had 0 risk factors were the favorable risk, who had the best outcomes as expected, better than the intermediate and the poor ones. And then they did an external validation of this tool with over 1,000 patients who were not a part of the initial IMDC. And this was published back in 2013. And it again showed that the favorable risk patients lived much longer than the intermediate and poor risk, which is self-evident. And now in the era of immunotherapy, they wanted to validate this with today's therapies because just TKIs is not the standard of care anymore. And this slide is courtesy of Dr. Heng, the founder of this, and they published this in European Urology this year. As you can see, the tool still holds good whether patients are getting Ipi-Nivo or any immunotherapy TKI or just VEGF therapy. So it's really holding true no matter what treatment patient is being offered in today's date. So what is the IMDC applicability in India? I did look up, if there's any retrospective data available from the Indian subcontinent, and I found that in this one tertiary care hospital in northern India, there were around, I think, 200, 300 patients. They looked at this IMDC score, and they also found that the poor risk do the worst. But the interesting thing here is that, as you can see, only 4% patients out of this were favorable. Majority were intermediate and poor. But if we look at the IMDC contemporary cohort, we see that favorable is much more and poor is only 31%. So that's why it's possible, that patients are getting diagnosed a little later here due to access or other issues, and by the time they come, they're already in the poor risk. But that tells you that this tool is also applicable in India. And there's multiple available options for frontline treatment for metastatic RCC. If you follow the ESMO guidelines, which I think in India, these are the guidelines people follow. So for favorable risk, you can use any of the immunotherapy TKI combination, except for avelumab, which didn't really show overall survival. But you can also use single-agent TKI if there's affordability problem with the immunotherapy. For intermediate and poor risk, there's the options of nivolumab, ipilimumab, or any TKI and immunotherapy. Again, single-agent TKI is not really recommended unless it's an access or cost issue. For patients who have sarcomatoid histology, we know that ipilimumab, nivolumab does better, but I think that is one of the drawbacks of the IMDC criteria because it does not take histology into account. It was developed for clear cell RCC. So as per the ASCO guidelines 2023, this is the algorithm that one can follow, and I'm sure this is what people here are following. If patients are not candidates for surgery and they have metastatic disease, you do risk stratification for frontline treatment. And if they have intermediate or poor risk disease, either offer them immunotherapy doublet or an immunotherapy TKI combination. If they have favorable risk disease, you can do a combination or just a TKI. And some of these patients can also just undergo surveillance if they have very small lung mets. But if they have favorable risk disease with a lot of comorbidities, then you can do a monotherapy or a combination, depending on what the comorbidities are and also taking cost into account. Actually, that's my last slide, so I gave back 5 minutes.
Yeah, Dr. Shilpa, just a question to you. From my own understanding, this you showed a slide of Heng where he says that IO still holds on in the IMDC, still holds on in the IO era. But my own understanding is that probably the 0 and 1 in the IO era behave similar in the similarly, but the 3 and 4 and 2 are different when you do IMDC risk criteria. I hope I'm clear. I used too many words. Okay, 0 and 1 look the same when you treat in the IO era, whereas the risk 2, 3, 4 look different. So probably the IMDC which Heng talks about doesn't hold true in the IO era, and there are publications from Israel which have looked at it, and other thing that it doesn't look at is the number of metastases. 0 to 1 metastasis or 1 to 2 metastasis are probably different from the rest, apart from the histology that you mentioned.
Yeah, you're right. I think it does not take into account the disease biology or the histology. So it obviously has limitations, but it has still helped develop a lot of trials. I think for non-clear cell histologies, we do need a different tool, and these are the kind of things that are easy to do because it's all, you know, retrospective analysis and validation with different cohorts.
Thank you very much, ma'am, for covering that. What we always say, anybody presenting with de novo metastasis is in himself either intermediate or high risk. And all these ones, as you started off saying that these were all retrospective databases of people who had metastatic disease, and majority of the time, they are recurrent metastatic. So patients underwent a radical nephrectomy some time ago and now presenting with metastasis. Because the moment somebody presents with de novo metastatic, you cannot have a favorable risk. That's the reason the only study that you quoted from India, favorable are 4%, wherein probably there were lymph node metastasis or something that was a resectable metastasis. That's why the time delay from diagnosis to systemic treatment was more than 1 year. I think somewhere along, for people like you who are at the forefront of this research, we have to differentiate between, like we do for prostate, de novo metastatic to recurrent metastatic. We can't just pull all of them into one and expect the same rules to be applicable.
Yeah, that's really a great point.
So the question of the cytoreductive nephrectomy, so how you tackle in your setup? So patient of intermediate or poor, at least of intermediate risk presenting, not much hematuria or asymptomatic for that. So for a TKI, the debate is practically settled down with the Carmina and the other trial. But what's your practice for in IO TKI era regarding the cytoreductive nephrectomy, upfront or delayed?
And I know the clinical trials are still going on, like the PROBE trial through cooperative group to address this. As a standard of care, we are not doing it unless, you know, patient is very symptomatic and they've only seen the urologic oncologist. We try to put them on trials or just start systemic therapy. And then if, let's say, they've had a really tremendous response elsewhere, which is durable, then we talk about the nephrectomy.
Just another point, the cytoreductive nephrectomy, the evidence came from interleukin and interferon alpha. So do you think, compared to what we know, the Carmina trial, wherein we are using a TKI, there would be more influence or less influence of cytoreductive? I know we can always say that we can await the trials, but I'm thinking that they would be better because the evidence for cytoreductive nephrectomy came from immunotherapy.
Yeah, I agree with that. I think the current trial that is ongoing, it's called the PROBE trial, that will really address this question in a systematic manner.
Thank you.
Thank you, Dr. Shilpa Gupta. And now the last session, which is a case-based discussion on the renal cell carcinoma, the India-specific scenarios. To moderate this session, I would like to call upon Dr. Aditya Pradhan, who's the Director, Uro-Oncology and Kidney Transplantation, Venkateshwar Hospital, Delhi. And as panelists, I call upon Dr. Narmada Gupta, who's a Professor Emeritus, Urology, Medanta Medicity, Delhi. Dr. Saurabh Bhargav, who's the Senior Consultant and Medical Director, Uro-Oncology, Mazumdar Shaw Cancer Center, Bangalore. Dr. Sridhar GK, who's a Consultant Uro-Oncologist at Thangam Cancer Center, Namakai. Dr. Kaustav Talapatra, who's the Director, Radiation Oncology, Nanavati Max Super Specialty Hospital, Mumbai. Dr. Vinayak Makka, who's a Consultant Medical Oncologist from Bangalore. Dr. Swapnil Rane, who's a Professor and Pathologist from Tata Memorial Hospital, Mumbai. Over to you, sir, for your discussion. You've got 40 minutes. Thank you.
At the outset, thank you, organizers, for giving us this opportunity. Last batsman of the day. Let's go down to the first case. You've seen some of this through these last 2 days. So, a 70-year-old with a history of his brother having died of kidney cancer at age 62. He is presented with 4 months flank pain. Have a look. Can you see the video? Yeah. The GFR on the right kidney and the left kidney, 38 and 32. Right. So the diagnosis probably is obvious. Dr. Gupta, sir. Obviously, diagnosis is simple, sir. We are talking of a VHL patient. What is your plan, patient-focused?
The patient-focused plan will be to do the surgical management. And first we do a X-ray chest or CT chest if it has not been covered already, and to see that there are no metastatic disease or any involvement of any other organ in the body. Then surgery, I think so, is the treatment of choice. We start with one side, and then we take not simultaneously, sequentially on the other side. And obviously, the enucleation of the tumor has to be done.
Right. So we roughly went according to the same plan. I'm now focusing on the right kidney, which had a little better GFR. There was this kind of picture, a large solid mass, few cysts, big volume, one cyst lower part. I sat down with the radiologist, and roughly this is what he showed me. Below this, nothing. Above this, nothing. So we ended up doing a robotic right side heminephrectomy. This is what came out. RCC, grade 2, margins clear. Now, after a few months, actually precisely 6 months, we started looking at this, the left kidney. Sridhar, how would you plan this side now? You've already done right. There is 50% function on that side. You have 32 GFR here. Multiple locations, multiple cysts are there. So when you are taking up this patient, can you answer these questions? Like, would you go open? Or in your center, you would straight away say, no, this is lap or robotic. And when you actually do it, you're going to clamp it and then go over 35, 40, 50 minutes ischemia time and then take out all of it, or unclamp at some time and then go for the next. How do you work it out?
So this patient is a VHL patient.
Yeah.
So he's gonna get tumors again in his lifetime. So my prime idea is to preserve as much renal parenchyma as possible, at the same time to keep the warm ischemia to the minimum. So for this patient, I will prefer an open partial nephrectomy.
Okay.
I will try to enucleate the tumors without clamping. Whenever there is
without clamping?
Yeah,
okay.
I will try to enucleate. Whichever is possible, I will take as much as possible. In case if I need to clamp, I will clamp, cool the kidney, take out the tumors which are completely endophytic. All those areas alone, I will try to clamp. The rest of the thing, I will try to enucleate without clamping.
Okay. So this is what I found actually. We have gone robotically, but you see this landscape. Multiple cysts are there. Some areas solid, some are completely endophytic solid tumors. So this is the kind of picture that you get in, when you've dealt with VHL. Any inputs you would like to give having seen this now? So the point we're trying to say is manifold. It may not be feasible to take out everything at one go. It may not be necessary also. So let's take some more questions on this. Swapnil, about the cysts. How particular would you be regarding every cyst to be removed? Because when you looked at the CT, there was not evidence of high grade, a type 4 cyst in all. One area, yes, there seems to be a type 4. The rest seem to be type 1 or 2. So is there any truth in this, that cysts may progress to malignancy? Would you like to comment on the underlying RCC pathology that you would find here? And some brief comments about genetic markers if you would like to suggest to the patient.
So not every cyst is going to progress to malignancy, and of course the complexity of the cyst that we see would be more important. What as a pathologist, what we look at usually is we'd like to look at the cyst walls. If the cyst walls are quite thick, then that is something that we sample very extensively, and we try to look for any clear cells in those particular areas.
Okay.
The commonest pathology would obviously see is a clear cell in this particular scenario. There is, apart from VHL, the CA9 that we commonly use as a marker pointing towards the VHL gene being affected or the hypoxia pathway being affected. I am not aware of any other genetic markers in this particular area.
Right. Kaustav, I have a scenario where I have done this patient. I have not really been able to get out everything. I didn't make a very serious attempt to take out 2 large endophytic masses which remained there. What would you suggest to the patient? He has some residual disease there which I have probably not removed. The patient comes to you. Anything you can offer him?
So SBRT is emerging evidence. If the size is less than 7 centimeters, actually the evidence is primarily for primary tumors, medically inoperable, but if there's a